Hello, everybody, and thanks for coming. My name is Matt Gordon. I'm the Director of EMS here at Trumbull Regional Medical Center. I'm here with Larry Monero, BAS, Nationally Registered Paramedic. We're going to talk today about Trumbull Regional Medical Center's new cardiovascular protocols for 2021. So without any delay, let's get started. This protocol has been inspired by some of the things we're doing inside of the hospital and is going on in EMS around us, with the basic goal of reducing first medical contact to reperfusion time in MIs and STEMIs. Trumbull has committed itself to reducing the amount of time it takes for your patients to receive definitive care, and we've set our target times far below the national standards for cardiac care. To that end, you're going to see when we get into the protocol that we've set some lofty goals, and we understand that the bar is very high here. What we're most concerned about is for everybody to realize that this is a time-sensitive thing, and the faster we get this person to the hospital, the faster we get the EKG to the hospital, all of these things are going to add up to a great outcome for our patients. So what we're looking for is from first medical contact to you getting an EKG is less than or equal to 5 minutes. Now, I understand that there's a lot of things that go on an EMS call, and they're not all the same. It might take you 5 minutes to get Grandpa's shirt off. So when you do have delays, please document those in your run reports so that I can weed those out. Once we've gained our EKG, I want that transmitted in less than 5 minutes. Even if you're in the middle of an extrication or something in the home, if it's going to take a long time, when you get the EKG, send it. This is going to go for all cardiac events. We'd like those EKGs sent as quickly, as early as possible. It gives our cath lab team much more time to get to the hospital and prepare. So with those two combined, we want the first medical contact to the actual STEMI alert to be less than 10 minutes. And again, I understand that's a lofty goal, but I just really want you to keep that in the back of your mind and understand that we're trying to move forward very quickly. Then once we get to the ED, the throughput for EMS patients should be less than 10 minutes. Where EMS comes in for that is helping out, is getting those blood draws done and these treatment modalities completed so that we can move quickly through the ED to the cath lab. So far it's working. We've made some changes in-house. We've made some more emphasis on some of the things outside in the EMS world, and so far it's working. So far in 2021, in the first quarter, we dropped our first medical contact to reperfusion to 77 minutes. We had set a goal of 90 minutes, which was actually a fairly lofty goal, and quite honestly, we're kind of crushing it. But I want to see that go way lower. And you can see that in April, we were down to 63 minutes, which is amazing. I anticipate a little bit of a bump up in our next quarter because we had a couple of incidents. One was where we had 2 STEMIs arrive at our hospital within 2 minutes of each other. So there are outliers there, but I'll be sure to keep you all posted on those kind of statistics. Percentage of STEMI patients with a first medical contact of EMS to primary PCI. We wanted that done within 90 minutes. In 2021, year to date, 67% of those patients are getting that done within 90 minutes. Our goal was 50%. If you look down at the bottom, in 2021, we improved over 38%. In 2020, that only 29% of these patients met this parameter, and now we're up to 67%. And this is just being done in-house with diligent record keeping and everybody really being on the same page, and our cardiac team being very focused on this program. We have a lot of support from inside the hospital for this, which should make our life a little bit easier in EMS. So to that end, we've decided to make some changes. There's a lot of changes coming in our protocol, everything from the format to some of the way we wrote things to the treatments. I understand that, everybody hates and loves change. They always say in the fire service, 2 things we hate are when things change and when they stay the same. Well, here comes the change. The first thing you're going to notice is the format. The format's been cleaned up quite a bit. It's very linear. I think it's very clean looking and should be valuable for a reference device. We want you to be able to use your protocol book, whether it be in paper or on PDF. We want it to be usable for you. So we've added a few things. The first one being these time reminders, which we talked about in the first couple of slides. These time reminders are here, like I said, to try and just keep you on track, to make sure that we all understand that we're moving forward. The cliche that time is muscle is a cliche because it's true. If we can shave 10 minutes off of off the time that somebody's myocardium's not getting blood, that's a huge, huge difference. Next thing we've put in is some alerts. And these will be signified by the black diamonds. So you can see here that all cardiac events will be transmitted to the ED. That does not mean that you're calling a STEMI alert, but we just had a cardiac chest pain meeting today, and it turns out that most of the STEMI alerts are actually coming from our cardiology team. And it's not that the ED isn't getting it done quickly. It's just that when our cardiologists or when the head of our cardiology team gets that EKG, they activate it right that second. You're also going to get that same activation if you don't transmit. If you call us up and say that you have a STEMI, you're going to get a full activation. And later on, I'll show you a statistic that why we're allowed to do that. Another one of our alerts is down here. It's about nitroglycerin. We do not want you to withhold nitroglycerin if the blood pressure is above 100, even if you're unable to establish an IV. The good outweighs the bad on this treatment modality, and we want to make sure that nitroglycerin gets in, and then we're starting to get that venodilation right away. The sooner the better. And that brings us to the changes in treatment. So these won't be highlighted in the final protocol or anything, but just highlighted to show you a little bit. And the first change you're going to see is our change to oxygen. We're going to titrate our SpO2 to 90%. That's following the same line of thought and the evidence across the board that shows that we don't need to get that non-rebreather on people. We want to keep that SpO2 in this range to reduce those free oxygen radicals that we've been talking about for a couple of years. The next change, we already touched on it. Transmit that EKG and notify the facility. Folks, if you can call Trumbull a half an hour before you get here, that's great. That's what I'm looking for. I would love to have that EKG way, way, way before you get here. The value to that is I want the cath lab waiting for you when you get here. And they've been really, really diligent. Everybody from the doctors to the nurses to everybody else on that team has been diligent with their response after hours. And in fact, most of our STEMIs occur after hours. The vast majority occur after hours. So it's really important that we get these folks moving towards the hospital as quickly as possible. If we look down this side, we're going to go down the STEMI side first. Here's a big change, and this will be touched on again later in the lecture, and we're going to show you a little demonstration. We need to apply the AED pads in the anterior posterior position. That is at the recommendation of our cardiologists. That's at the recommendation of our research. We're going to show you a couple different ways to defibrillate, and you'll see how this comes into play, especially with a lot of us having Lucas devices now. So keep an open mind about it for right now. Next is that Brilinta. We want to get that Brilinta on board as early as possible in a STEMI. So don't be afraid. Get it in there and begin a rapid transport to a PCI facility. There's not much point in doing all this treatment and everything and taking them to the wrong hospital. Please make sure that you are going to the correct hospital, to a cardiac hospital. So if you see our time reminder over here, we're looking for less than 15 minutes on scene. And again, I understand that sometimes that's a lofty goal. Sometimes you can be off scene in 5 minutes if you work at it. So the idea is you're not going to be gigged for being on scene for 16 minutes. We're just trying to keep it in the back of your mind. The next one, draw labs. Man, I want those labs drawn. Folks, they're doing a great job. The ED staff has embraced it. We are using your bloods. We're running the labs off of your bloods. You've done a great job so far. The people that are doing it, you've done a great job so far with the labeling and sticking to the system. And I appreciate that. And we're going to keep that up. And it may our blood draw program may even be expanded a little bit here in the very near future. The next change on the STEMI side is heparin, 60 units per kilogram, IV or IO, with a max of 4,000 units. What that works out to is any patient over 147 pounds is going to get the whole dose. Without being too candid, let's face it, most of our STEMI patients are probably going to be over 147 pounds. But understand that if they're lighter than that, if you do have a slightly built person, to do the math and get it right. But over 147 pounds is going to get the whole thing. If we look down the chest pain non-STEMI side, there's not a lot of changes, but the one that's really important is drawing those labs. So far, in just the couple of months that we've been drawing labs, and not every agency has been doing it, in the couple of months we've been drawing labs, I know for a fact that 4 people, their troponin levels have been documented by EMS blood. What that does for us is once that patient gets in the ED, even if we're lightning quick on our blood draws, in-house, there has to be an order. Then that order is received by the PCT. Then the PCT goes and draws the bloods, and then it goes to the lab. So even if we're doing that very, very quickly, it takes some time. The beautiful part about EMS bringing your labs in is our staff has been instructed, and I'm sure you'll find that they'll comply, that when you bring these labs into the hospital, they're not to look for a reason to not use them. We're looking for a reason to use them. So once they make sure that those labs are properly labeled and everything, those labs from EMS are hand delivered to the laboratory and get processed immediately, especially in these cases when we're looking for a troponin level or some other critical lab value. So please keep up on that. If you're not doing the blood draws, please do them. The kits are available. I can bring them to your company or department if you like, or you can come and pick them up in the ED. They are on the shelf in the EMS lounge. So Brilinta, this is a new med for us here at Trumbull. Its mechanism of action is it's a P2Y platelet inhibitor, and that means that it's not a clot buster. It's a clot not getter biggerer. We're keeping these platelets from sticking to each other so that our problem doesn't get worse. It's always been my first rule of EMS has always been don't make it any worse. Well, this is going to help us not make it any worse. We're going to try and stop it in its tracks. Its only indication for our protocol is for STEMI. The dose is 180 milligrams by mouth. That's 2 tabs. Contraindicated by hypersensitivity, history of intracranial hemorrhage, or active bleeding. I think that's fairly self-explanatory. The possible adverse reactions to Brilinta are the bleeding and dyspnea, and we want to keep our eyes out for that, although it is a very rare reaction. We're going to use caution with other direct antiplatelet acting medications, although we will continue with the aspirin, and we want to give that as early as we can in a confirmed STEMI. If the EKG, if you interpret that to be a STEMI, the Brilinta should be in. Heparin, its mechanism of action is it is actually an anticoagulant. We're going to start breaking the clot down, or at least prepping it to be broken down and to be moved in the cath lab. Our only indication for our protocol is STEMI. We talked about the adult dose is 60 units per kilogram IV or IO to a max of 4,000. So don't forget that magic number is 147 pounds. At 147 pounds, they get the whole dose. Contraindicated by hypersensitivity. And don't forget to ask if they're allergic to heparin or Brilinta, because they may know, they may have been through this before. So we want to make sure that if they are allergic, we don't want to be giving it. Active bleeding, known bleeding disorders. Again, you have to ask those questions, get that history. Trauma. Be careful in chest pains caused by trauma. A blunt force trauma to the chest should not be getting, with chest pain, should not be getting heparin. Contraindicated by aortic dissection. So we want to make sure that we do a very, very good assessment of these patients. We want to assess them. We want to put our hands on them. We want to check for those paradoxical pulses. We want to ask the questions. We want to listen to their chest, do a good assessment, and we should be able to avoid that. If you have any question whatsoever of whether you should be giving any of these meds, either or any of these meds, that's what medical direction is for. Please don't hesitate to call medical command. And symptoms of a stroke or CVA. We don't want to be giving it if we're having a stroke or CVA. Sometimes MIs and strokes occur at the same time. We want to be careful of that. So do a good assessment. For asystole this year, there's no changes. None have been recommended, and we're not making any. The only thing you'll see is, again, some of the warnings and stuff that are here for resuscitation. Bradycardia, there's no real changes, but I want to point out, if you look up here, when you have a bradycardic patient, new-onset bradycardic patient, get that 12 lead done. We have a high suspicion of an inferior wall STEMI. So have a very high suspicion. If you go to take their pulse and it's 30, get that 12 lead and get it early and send it in. Down here is just a little reminder about the epi push dose pressor. Don't be afraid of this treatment modality, guys. This is a great and safe treatment. And you'll see later on that we're trying to keep the mechanism for a lot of these medications the same. And don't forget, with the epi push dose pressor, it's 10 cc syringe, waste one, draw one, and continue with your protocol. So you're gonna see that mirrored later on. This is one that we're going to take a few minutes on about CCR and CPR. And Larry, feel free to jump in on any of these as I go through them. CCR is not a reason to discontinue our resuscitation efforts. CCR is designed to circulate oxygenated blood in the body, which is more important than airway or anything else, for that first 10 minutes, so that we have a chance of getting ROSC back in these patients. So if you have a cardiac related issue, if you have a healthy person that keels over, they should be getting CCR. If you have someone who choked to death or is a result of trauma or any of these other things that you see up here, if you know they're a respiratory arrest, then that's a respiratory problem. It's not a cardiac problem. Drowning is a respiratory problem, not a cardiac problem. So those should be CPR. So look at the CCR. We're going to touch on the PIC crew a little bit later on, but consider that CCR with the PIC crew protocol, and we'll talk about growing that protocol a little bit. Epi and defibrillation are the only thing that this patient should be getting in the first 10 minutes. No antiarrhythmics should be given in the first 10 minutes in CCR. We're getting the heart ready for defibrillation, getting it ready for, we're trying to circulate this already oxygenated blood. The oxygenation takes a while the dissolved oxygen in the blood takes a little while for it to deplete. So we're going to take advantage of that in the first 10 minutes.
So if I were to suddenly collapse right now, a 35-year-old male, I don't have a needle in my arm, I'm not complaining of anything, we have to expect that it's my heart. And furthermore, if we have an elderly patient collapse, we have to assume it's their heart that caused that. And the new resuscitation guidelines focus on decreasing the interthoracic pressure. And so we need to really start that pump again. If you take my pulse ox right now, it's probably 98%. If my heart stops, the problem is not the oxygen dissolved in the blood, it's the pump moving that oxygen to the rest of the body. So this is where CCR, again, comes into play. So science shows, and there are several studies done by different department of EMS across Arizona and I believe New Mexico and Minnesota, that if you implement the CCR protocol and you start with compressions, you give epinephrine as every 2 minutes intervals, and you do defibrillation, that these patients can actually have ROSC rates in 38 to 40%, which is awesome. So we really need to focus on chest compressions and epi and defibrillation as necessary for the first 10 minutes. Now, that means that if they're in a systole for 10 minutes, we do chest compressions and epi for 10 minutes. If they're in VFib, VTAC without a pulse, we still only do chest compressions and defibrillation for 10 minutes. We're not going to amiodarone until after that 10-minute mark. So epinephrine and defibrillation for the first 10 minutes, and nasal cannula or non-breather with high flow oxygen and then tidal, 10 minutes. After that 10 minutes, we reassess that patient. We look for the rhythm. If the patient is in asystole, we continue on with the asystole algorithm. We do not terminate at this point. If the patient is still in VFib or VTAC, at this point, at the 10-minute mark, that's when we go ahead and we start to give the amiodarone and continue on with the arrest. And one of the other things that Matt's going to talk about too is you're going to see that the third defibrillation is going to have a vector change here. The third defibrillation is going to have a vector change. And just to tease us a little bit, all cardiac arrest, all bradycardic patients, all STEMI patients should have the anterior posterior AED pads put on. The reason for that, if you do have somebody go into arrest and you have that Lucas device or you have some other mechanical device, you don't have to worry about stopping compressions to roll that patient to put the anterior posterior on. After the second shock, we're actually going to put on a second set of pads in the normal anterior and lateral position so that on our third shock, we actually disconnect the AED pads in the anterior posterior and we put it on to the anterior lateral, because the idea is maybe we're not getting the ectopic foci with defibrillation in one vector, one direction, so we need to hit it with another one. And so that's where the science is going, and we want to be the first to kind of bring it to this area. So vector change is going to be huge. It's going to be important, especially as we move on, and hopefully we'll be able to show you a video here of how it works and why it's important. But again, change that vector at the third shock and then continue on with your rest. Again, for another 20 minutes after you get to this 10-minute point, we're going to continue on with your rest. And we want to emphasize to work that patient where they're at so that high-quality CPR is being done, and we can assure that there's no danger to the provider or the patient as you're running right to the hospital. Again, after that 10-minute mark, you can choose to intubate or be aggressive with that airway. But again, if it's cardiac related and within the first 10 minutes, we just want to do passive oxygenation until we get to that 10-minute mark, and then BVM, King airway, or intubation as necessary.
Thank you, Larry. So on all these pages, you're going to see a page that follows it, and these are called pearls. And all of these are little bits of information, things you should consider, different, you should really take a look at these when you get your protocol. You should take a look at them because they have some really great points in them. So I'll just go over a couple of them in here. I'm not going to go over every single one. Don't forget to use passive oxygenation with CCR. Only epinephrine and defibrillation within the first 10 minutes. Be careful not to hyperventilate. Don't interrupt compressions to place an endotracheal tube. There's just different things like that we should know. If end tidal CO2 is less than 10 millimeters of mercury, you need to improve your chest compressions. If EtCO2 spikes, typically above 40, then you have return of spontaneous circulation. So all these different little tidbits are good to know. They're all things that you probably know, but it doesn't hurt to have a reminder. Our hypertension protocol doesn't have any changes. Just understand that a lot of times hypertension has an associated issue. So hypertension with chest pain should go to your ACS protocol. Hypertension in a pregnancy should go to maternal hypertension protocol. So, yes, we don't do a lot to treat hypertension by itself, but we need to take a look at the causes and the underlying problems and see if we can solve those. Narrow complex tachycardia has one pending change. We're looking at CardioZem, 0.25 milligrams per kilogram for a max of 20. Once that goes into the box, everybody will be notified and everything else along the regular channels. So we're looking at that, working on it. Until that point, if you get to this point in the protocol, you'll still be using the amiodarone, 150 milligrams over 10 minutes. And obviously, if you're unstable, then we're going to go to cardioversion and all the fun that comes with that. If you have time with cardioversion, try to sedate them. It can't be much fun. Wide complex tachycardia, there's no changes this year. Again, just want to point out the different time constraints and the different points of information. So take this one. If pregnant or allergic to amiodarone, you make sure you use lidocaine. Just little tidbits of information that'll help you out. VFib, pulseless VTAC. There's only one real change, but it's a doozy. After that vector change, now we're looking at double sequential defibrillation. Say that a couple times fast. And there's been some talk about this throughout the whole EMS community. It's using two monitors to defibrillate at essentially the same time. And if you remember what Larry was talking about that vector change, that's trying to take a different shot at it. So imagine a sniper's trying to hit something and they can't hit it from one direction, so they move over to another direction and they still can't hit that irritable foci. Well, now we're going to drop a bomb on it. So if we don't defibrillate 85% of the irritated myocardium, it'll probably go back into fib. So this is going to be a process that you're going to see. And in the video that we're going to show you, they actually kind of prove our point about anterior posterior pad placement to start with.
One of the new things you'll see in the protocol is double sequential defibrillation. I'm going to go over what that means and when we use that real quickly here. So if you've ever had a case where you had a patient who was in ventricular fibrillation and you shocked them at the maximum joules and nothing happened, they stayed in VFib. These are the cases we're talking about. Basically, the purpose of defibrillation is to put the heart into asystole with the hopes that the sinus node will then come back and take over the function of the heart. What happens in intractable ventricular fibrillation is you give the energy and it's not enough to shock the heart out of VFib, and the patient just stays in VFib. So normally what you'll see is you'll have VFib, you give the shock, and then you have a period of asystole afterwards, even if it's only for a few seconds. That's not the case I'm talking about. The case we're talking about is you have VFib, you shock them, and immediately after the shock, it's still VFib. It never put them into asystole. One of the theories why this occurs is that as the energy goes through the heart, you're getting part of the heart, but not all of the heart shocked at the same time. So what we're going to do for these cases, what the studies are showing that we can actually save some of these folks that up until now, universally, they all die, is you use two defibrillators. And what you do is you put the pad in our usual standard location in the beginning, and then if it turns out that you need to use the second defibrillator, what you do is put The second pad's anterior and posterior. So now what you're doing, you've got the energy vectors going in two different directions. So the surface area of the heart that gets shocked is much larger, and you're much more likely to get the entire heart shocked and defibrillated at the same time. So you'll put both of the pads on, 2 monitors, both at max setting, and you go 3, 2, 1, and push both pretty much as close to the same time as possible. And that will convert some of these folks and will be able to save some of their lives.
So I'm just going to echo what Dr. Shepke said real quick and tell you when we're going to perform this actual double sequential defibrillation. So this patient has been in cardiac arrest for quite a while now because we've maxed out on our antiarrhythmics. We've given 2 separate doses of amiodarone, the first being 300 milligrams, the second being 150 milligrams. We've standard defibrillated the patient probably 4 or 5 times by now. And then when we bring in the second monitor, we've confirmed on both monitors the patient has remained in VFib and is remaining in VFib. So bring in the second monitor, put on the second pair of pads, and we're going to go ahead and perform the procedure. So you'll see the Lucas is already running on the particular patient, and the crew's going to stop the Lucas machine, and they're going to pull it off and start manual compressions while the person working the life pack is going to hook up the additional life pack and show you how this procedure goes. So the first thing is we're going to go ahead and power the second life pack on, and then we're going to get a set of combo pads, and we're going to go ahead and put them on the patient. Now, as you see, there's already a set of combo pads in the normal position as we would usually be defibrillating the patient. These pads are actually going to go on the anterior and posterior section. So you'll see the chest compression person stop, resume chest compressions, and then we're going to log roll the patient using all 3 of our crew members and put the pad on the posterior portion of the patient. So they'll demonstrate that at this time. And then when you see them put them back down, they're going to resume chest compressions. The goal is to minimize the hands off the chest time. So now you'll see that the person working the LifePak 15 is going to switch it over into paddles and confirm that both monitors reveal VFib. After that's done, the person working the monitors is going to go ahead and charge both of the monitors to the maximum setting. So as you see, both defibrillators have charged up to 360. He's going to clear everybody and make sure they're clear, and then he's going to attempt to push the shock button simultaneously.
Let's move on to ROSC. So everything we've done works, right? So everything works, and now we've got ROSC. We've got return of spontaneous circulation. There is a change or a note we want to make when you get ROSC. We want you to be really careful about grabbing somebody up as soon as you get pulses back and throwing them in the ambulance and heading out. This whole lecture I've been telling you to hurry up, and now I'm going to tell you to slow down a little bit. After return of ROSC, we'd like you to stay on scene for about 5 minutes and continue your treatment. We want actual fingers on the pulse for a good 5 minutes, for the whole time. Watching the monitor for changes. This is when you're going to have your bradycardic events or the rearrest. So you want to make sure you have that push dose pressor ready to go. Get that epi ready, drawn up and ready to go. If you draw up these medications and stuff and don't use them, that's fine. That's absolutely fine. But I'd rather you be ready to go and prepared in case this patient starts to brady out or go hypotensive or rearrest, so that you're ready to go. So be careful about that. Try to calm down. This whole lecture has been about hurrying up, and now I'm going to tell you to slow down a little bit. When you do get ROSC, please get that 12 lead if you can, without risking your patient, without risking rearrest or anything. Please get that 12 lead and get it sent in as quickly as possible. Return of spontaneous circulation, STEMIs are a particular challenge, and a particular challenge for our cardiac cath lab team. These are when we really need that good documentation, guys. When you come into the hospital with somebody who has ROSC, or we get ROSC back, or even if you're bringing in a cardiac arrest and we're working it here, we need you to hang out. We need you to explain exactly, hopefully in writing, exactly the meds you gave and everything else, because it just really drives the care especially once this patient gets into the cath lab. Dr. Nador and Dr. Bhakta need to know what the patient was given and what happened and what you found. They place a lot of value on EMS and your assessment and what you do. So we need that information of, you got the pulse back. Now we need to know how'd you do it? These are some of the ROSC pearls. Make sure you get that end tidal CO2 on them. Have that epi push dose presser ready. Get that 12 lead if you can. We're gonna titrate our fluid resuscitation and vasopressors to maintain a systolic blood pressure of 90 to 100 or a mean arterial pressure of around 65. So again, these are all guidelines and everything. I know you're not going to be reading this in the back of the ambulance. The time to read these things is to familiarize yourself before you're put in the situation. So PICC crew CPR. Guys, this works great. And I'm going to go right to the next page. Here's the protocol for it. Here's the recipe. But by looking at the picture, so we've got 1, 2, 3, 4, 5, 6, 7, 8 people. Just like every other cardiac arrest you run, you have 8 people at your disposal, and the guy falls down right in the middle of the floor, right? So that's not realistic. That's not realistic. Most of us show up with 2, and hopefully there's 2 more coming. So I encourage you to if you have law enforcement there, if your law enforcement community in your community is helpful in this particular way and stuff, get them down there doing CPR. We want these people that are doing the chest compressions. If you don't have a Lucas device, we want these people to rotate every 200 beats. And that's not easy to do sometimes because, you have everybody's, no, I'm fine. You're not fine. 200 compressions, after 200 compressions, even if you're powerful enough, you're not going to be accurate enough. So we need to make those changes. And those changes should be made by who I call the quarterback, who, after you first get started and you start growing your scene, just like, as far as fire departments go and stuff, we have all kind of NIMS training and everything and incident command. And so we know how to grow a scene. We can grow a scene and we can shrink a scene, right? So we've grown from the first 2 to now maybe we have 4 or 5 people. We probably, very rarely are we going to have 8 people on a cardiac arrest. But if the person leading that cardiac arrest can step back and actually have the big picture, so they can see the monitor, they can see the compressions going on, they're ordering meds. That person, like I said, I call them the quarterback, or usually it's a captain. It's usually a seasoned paramedic. So I want that person to be standing back and running the arrest. If you can, like I said, at that point, maybe your hand shouldn't even be on the patient. You should be running this. You should be the ringleader of the circus. So, I mean, all of these positions are great. We have a med administrator. We have, compression 1, compression 2. This guy's in charge of the AED, And we want that militaristic approach, but the AED might not be over here. It might be over here or anything. So we're flexible. We can get this done. Understand the concept. The concept is to rotate these people through and to be highly, highly, highly efficient at our CPR. So without any further ado, I'm going to turn you over to Larry Monero. And Larry's been working very hard at especially this particular protocol, the acute pulmonary edema protocol. This is a cutting edge protocol. I'm going to let him explain it and everything because he just does a much better job of it than I do. But folks, take a look at this. Listen to what he's telling you. Listen to it. Listen how safe it is, how easy it is, and the evidence that comes with this protocol. This is a lifesaver. There's a lot of buzz about this actually throughout the entire Steward health system. So we're looking to make a big change here. So take it away, Larry.
Well, thank you, Matt. So again, I just want to reiterate that everything that we're doing moving forward is evidence-based. They've been journal articles have been selected from peer-reviewed journals that Annals of Emergency Medicine, Pre-Hospital Emergency Care Journal, GEMS, American Association of Cardiology, pulmonologists. So these are all studied, and I wanted to be one of the first in the country to bring this to you. And so I think what we're going to do with acute pulmonary edema is going to save lives, prevent ICU stays, prevent that patient from having to get intubated. And as we go through the lecture here, I'm going to take you through a little bit of physiology, pathophysiology of acute pulmonary edema, refresh your memory on how the heart works, and we're going to move into evidence as to why our new treatment is safe and effective. Just again, the new look of the acute pulmonary edema CHF page here. We're going to come back to this in a little bit, but this is what the layout's going to be. And I just want to show you that now we've taken acute pulmonary edema and we've divided it into mild, moderate, severe, and then cardiogenic shock. Again, you'll see these clinical pearls page, just little notes for you to kind of maybe figure out signs and symptoms or differential diagnosis here, and things to be cognizant of as you do your approach. Again, these maybe not to be in the event of the emergency, but to look over, or if you needed to reference to refresh your memory here. So again, most of us, actually all of us in EMS, we know what acute pulmonary edema is. We know that it's pretty much called heart failure. But what I want to do is I want to take your conventional congestive heart failure and put it into one category, and I want to take a new ideology and put it into the second category. So first, to start with your typical heart failure. When we talk about your typical heart failure, we know the pathway of the blood, right? We know that the left ventricle is supposed to pump blood into the aorta so it can be delivered to the rest of the body. But typical heart failure is when that left ventricle kind of either gets hypertrophied or cannot pump forward the amount of blood, reducing the stroke volume out. So when you reduce the stroke volume, that blood's got to go somewhere. And that blood is going to back up into the left atrium. That left atrium is going to back blood up into the capillaries. And it's going to eventually go into the capillary system where the hydrostatic pressure is going to overload. And when blood and the hydrostatic pressure overloads the capability of the capillary, fluid's going to escape out from that capillary and go into the interstitial space. Once that interstitial space fills up, it's going to flood over into the alveoli. And so that's your typical heart failure. We know that we have elevated cardiac filling pressures. We have the accumulation of the fluid that moves up. And sometimes this can actually lead into cardiogenic shock as you start moving fluid from the vascular system into the interstitial and alveoli. But as your blood pressure starts to drop, you actually have a release of catecholamines. We're going to go into the cycle here soon. But there's a new type of pulmonary edema I want to introduce to you, and it's called SCAPE, and that stands for sympathetic induced crashing acute pulmonary edema. Now, these patients, they're going to be a quick onset. Think of your flash pulmonary edema patients, or think of that CHF patient who's been waiting to get treatment, waiting to call the ambulance, and all of a sudden they go into this. All right, this is going to be a rapid progression of symptoms where you have a massive amount of fluid overload, and I'm going to take you into the pathophysiology here. So in stage 1 of sympathetic induced acute pulmonary edema, we have that distension of the small capillaries in the pulmonary system due to increased atrial pressures. As we previously stated, the left ventricle can't pump forward, therefore backing everything up into the left atria. When the left atria gets backed up, we increase the pressure into the capillaries. So those pulmonary capillaries, they distend to a certain point. And then what's going to happen is the hydrostatic pressure is going to allow that fluid to go out from that capillary into the interstitial space, and that's going to be stage 2. As that interstitial edema accumulates, that's actually going to move to stage 3, where we actually flood the alveolar space. And when we start to get fluid into the alveoli, that's when these patients will complain of some shortness of breath, and we'll actually have some hypoxia going on. When we get into stage 4, the pulmonary overload stage, we actually start to have a release of catecholamines, your epi and your norepi. And when those are released, we actually have an increase in an increase in heart rate. And if we have an increase in heart rate, and we know that the stroke volume is already reduced on the left ventricle and we can't pump it forward, we're going to actually make things worse. That cardiac output is going to go down. And so we have decreased diastolic time, decreased filling time. So again, we're not pushing anything forward, causing more fluid to back up. When more fluids backs up and the system realizes that the cardiac output has gone down, we're actually going to have the activation of the renin-angiotensin-aldosterone system, which is going to essentially try to increase SVR and is going to try to increase and clamp down to actually help to, for lack of a better term, help that cardiac output that it thinks that it's missing. And when that happens, we've already have the fluid in the capillaries, and when we clamp down, that pressure goes up, leading to more capillary permeability. And that's going to flood the interstitial space even more, and that's going to flood the alveoli even more. And these patients are going to be severely short of breath. Some of your clinical features of the sympathetic-induced crashing acute pulmonary edema is they're going to be short of breath, all right? It can progress from minutes to hours. They're going to be very restless. As with most cardiac or respiratory symptoms, presentations are going to be diaphoretic. When you auscultate, you're going to hear crackles, and this is big. Crackles, we know that we have fluid. Wheezing, we know we have bronchoconstriction. So these patients will have crackles. They're going to be orthopnic. They want to sit up versus lay down. All right, these patients might have slept overnight in a recliner because they can't lay flat on their bed. Their SpO2 is going to be low, so they're going to be hypoxic. They're going to be hypertensive, and we talked about the increased heart rate, the norepi, the epi, the activation of the renin-angiotensin-aldosterone system is going to try to increase that SVR and spill out more fluid. And they're going to be in respiratory distress. So how do we manage these patients? How do we manage acute pulmonary edema, and how do we manage these SCAPE patients? Well, historically, back around 2010 and before, the treatment was, let's give some morphine and let's give some Lasix. Well, the Lasix, we found out that, if you are taxing the system, the kidney, the renal system, and you are trying to have a shift of blood flow, giving Lasix to have reabsorption of fluid in the loop of Henle is not really working because the kidneys are already taxed and work too hard. So in 2015, the research said, let's get rid of morphine, let's get rid of Lasix, and let's try to do some nitro, either sublingual tab or some nitro paste, and let's combine that with CPAP. Well, that was pretty good, and we saw some effects, but once you had that nitro under their tongue, and then you put on CPAP, did you really want to break that seal and allow that patient to not have that pressure infused to ease their breathing, or did you just go with nitro paste? And a lot of providers weren't really finding a nitro paste to be effective. So now what we're going to do is we're going to do 1 milligram of nitro given IV push every 2 minutes with CPAP rapidly titrated up from 5 to 6 centimeters of water all the way up to 12. So before we get to the actual pharmacology, let's talk about non-invasive ventilation. CPAP and BiPAP, we've been using this for years in EMS. There's no difference in safety and efficacy for pulmonary edema and SCAPE. BiPAP decreases the work of breathing during inspiration, where CPAP allows that back pressure to stent open the alveoli. They both provide oxygenation, again, open the alveoli, and they decrease dead space ventilation. It will decrease preload and afterload, but it takes 1 to 5 minutes to have positive effects. So going back to what we started doing in 2015, once you had that sublingual nitro under their tongue and you did put them on CPAP, you broke the progress of what we just did to try to allow them to breathe easier. And it could take 1 to 5 minutes again once you put that CPAP seal back on them if you had to put in more sublingual nitro. So we want to prevent that from happening. And then we know that CPAP works very well and it decreases the rates of intubation and mortality. So it's a great tool to EMS. When we talk about nitrates, at low doses, we get venodilation, and that decreases preload, and that's essentially what we want when we have a cardiovascular event. We want to give that 0.4 sublingual nitro every 3 to 5 minutes because we want to decrease the preload. By decreasing the preload to the heart, we decrease the oxygen demand, decreasing the workload, and we can save these patients when they go into the cath lab. But venodilation doesn't increase any further as we give more nitro, especially in the low doses. So what we need to do is we need to give high doses of a nitro because that's going to dilate the arterioles and resistance vessels, and it's going to decrease afterload. And again, going back to the pathophysiology, what happened? We had the release of epi and norepi. We had the increase of the heart rate, but we had the renin-aldosterone angiotensin system that clamped down on the SVR, and that's what's causing these patients to become worse. And that's where SCAPE involves, and we need to give the high-dose nitro so we can arterially dilate those vessels. let's compare some of the nitroglycerin types that we have out there. We have paste, sublingual, and IV now. So when we talk about a couple terms, this category here is going to tell you about the type of nitro. This category, bioavailability, and what that term means is the amount of drug that's usable by your body once we give it. The onset is when it starts to work. The peak effect is the maximum effect of that medication, and duration is how long that it lasts. So I told you before, back in 2015, people were saying, well, nitro paste. It was a great idea because we didn't have to break that seal, but it really wasn't working that effectively that EMS providers saw. So nitro paste only has 56% bioavailability, which means we put down that 1 inch of nitro paste, we're only getting 56% of that drug being absorbed. It can take up to 1 hour to work, so we really weren't seeing change pre-hospitally by the time we got to the hospital. The peak effect is about 3 to 4 hours, but here's the interesting thing. Once it did start to absorb, that duration lasted for up to 8 hours. So essentially these emergency physicians and these respiratory therapists, they had to deal with the effect of our nitro paste lasting for hours after they were in the ER or admitted upstairs. Sublingual nitro has a broad range of bioavailability between 38 and 50%. And I think anybody who's given nitro sublingually with a pill form knows that if you have a moist oral mucosa, great, that nitro would dissolve. But if you're very dry, that nitro does not dissolve very well. So that's where this 38 to 50% bioavailability comes in. The onset is quick. It's 1 to 3 minutes, and the peak effect is in 5 minutes, which is why we repeat nitro in the acute coronary syndrome every 5 minutes. The duration, though, can last up to 25 minutes. All right. With IV nitro, our bioavailability is 100%. In fact, any drug that you give intravenous has 100% bioavailability, which means we're getting all that drug into the body to have the effect. IV nitro is immediate onset, immediate effect, and it lasts for about 3 to 5 minutes. So it's going to act on the body quicker. It's going to have the maximum effects as soon as you give it, and the duration is a bit more manageable of 3 to 5 minutes. So now what I want to do is I want to take you into a couple different research studies here, and these research studies are essentially going to talk about the safety, efficacy of high-dose nitro and why we went the way we did here. So this first research study was published in the Pre-Hospital and Disaster Medicine, which is published by Cambridge University in 2013. And essentially what they did is they wanted to see if high-dose nitro given sublingually was safe. And so they had 100 patients total, and they had a regional EMS system protocol for CHF that said, if your blood pressure systolically was greater than 160, we're going to go ahead and we're going to give you 2 sublingual nitros. So a total of 0.8 milligrams of sublingual nitro. If your blood pressure systolically was greater than 200, we're going to go ahead and give you 3 sublingual nitros all at once. All right. And we're going to do that every 5 minutes as necessary. So of this study, 65 patients had 2 tablets, 29 patients had 3 tablets, and it worked pretty good. The mean systolic blood pressure dropped by about 14 millimeters of mercury, and only 3 patients had self-limited hypotension. And when we talk about self-limited, that means that blood pressure rebounded below 100 back up to above 100 without any IV fluids being given. Those 3 patients, and I'm going to tell you these blood pressures here. One blood pressure is 97 over 71, not bad. The next blood pressure was 78 over 50, still not too bad. And the third case of hypotension was 66 over 47. But within about 5 minutes or so, that blood pressure came back up, and they didn't have to have any additional fluid for that to happen. So this study, and along with a bunch of other studies, say that high-dose sublingual nitroglycerin is safe and rarely causes hypotension. We're going to talk about another study here that was actually published in the Annals of Emergency Medicine in 2007, and they're going to talk about the treatment of severely decompensated heart failure with high-dose IV nitro. So what happened with these patients is these patients came into the ER, and the emergency physicians actually treated them with the gold standard, which was high-flow O2 via non-rebreather. They got sublingual nitro. They got 60 to 80 milligrams of Lasix, and they actually had morphine on top of that. If those patients did not improve after all of that treatment, the high-flow O2, the morphine, the Lasix, the sublingual nitro, if they did not improve and their blood pressure was still greater than 160, then they dosed those patients with 2 milligrams of IV nitro every 3 minutes for a max of 10 doses, so up to 20 milligrams of nitro. And what they found out that it actually improved the patient dramatically. And here's some little test results here. When you gave the sublingual nitro, the high flow O2, you gave the morphine, and you gave the Lasix, they were finding out that around 27% of the patients were getting intubated. 20% of them were getting having to remain on BiPAP, and 80% of them got admitted to the ICU. And their troponin, their MI biomarker, was elevated by about 29%. 29% of the patients had elevated troponin levels. After they gave the IV nitro, with everything else that they threw at them, the rate of intubation dropped to 14%. Only 7% of the patients remained on BiPAP. Significantly decreased ICU stay and only 38% of these patients had to be admitted to the ICU. And the troponin level was only increased in about 17% of these patients. And again, one patient had a documented case of hypotension. So if we're throwing Lasix at the patient, we're doing sublingual nitro, we're doing morphine, we're doing high flow O2, and then we give high dose nitroglycerin via IV, and we increase oxygenation, we're going to decrease the rate of intubation, and these patients don't stay in the ICU very long, then isn't that a great tool to use? This study also shows that it's safe. And when we talk about the average vital signs here from that same study, you're going to see over here along the x-axis, you're going to see the time of arrival they're going to document in these 4 categories here, and then you're going to see time intervals here. And the time intervals here will be, you can see them labeled here 1, 2, 3, 4, and I'm not going to go beyond 4, but time interval 1 is about 16 minutes after arrival, time interval 2 is 21 minutes after arrival, 3 is going to be 24 minutes after arrival, and time interval 4 is 32 minutes after arrival. And all of these here that I'm going to talk about, after about 30 minutes after arrival with the treatment, these patients have started to improve. So let's look at the mean arterial pressure here. The mean arterial pressure of these acute pulmonary edema patients was about 140, all right? And again, the mean arterial pressure is calculated by your systolic and your diastolic blood pressure. So these patients are severely hypertensive, right? After about 30 minutes with the treatment, the mean arterial pressure starts to decrease to about 120, and it continues to decrease as the time goes on. And they found that IV nitroglycerin decreased the mean arterial pressure by about 50 millimeters of mercury, which is awesome. When we come down to the heart rate, upon arrival, the average heart rate was about 125-ish, all right? After 30 minutes with the IV nitro, we start to come down to 110, and by the time they were either discharged or admitted to the floor, you were back down to below 100. And the average decrease in heart rate was about 18 beats per minute. And that's great because we're decreasing the workload of the heart, and we're allowing for that left ventricle to fill up so we can move fluid forward. When we talk about respiratory rate, these patients were tachypnic, and the average respiratory rate was about 30 upon arrival. And after 30 minutes over here, you can see it decreases to about 28. And then after the whole treatment, you can see it's back down to normal. So on average, with IV nitroglycerin, it decreased about 8 breaths a minute. When we talk about the oxygen saturation, this is going to be a key thing as we continue on with this lecture. The O2 saturation, the average was about 92%. The lowest was just about 89%. And as time went on, within 30 minutes, the average SpO2 increased to about 95%. So we had an average increase in SpO2 of about 3% after these are all just after 1 dose of IV nitro. So you can see based on these vital signs that IV nitro actually clinically improved these patients with all the vital signs that are important with heart failure. Finally, there's another study here that's going to talk about the feasibility and effectiveness of pre-hospital IV nitroglycerin in acute pulmonary edema. And this was actually published in the pre-hospital emergency care last year in December. And so with this here, they actually allowed Montgomery County Hospital District EMS service in Texas. They included the study to have 88 patients. And what happened is they allowed the paramedic to decide how they wanted to treat the patients before they gave the IV nitroglycerin. So The reason of those 88 patients, only 48 were eligible was because 40 patients didn't have an IV, or that paramedic decided not to use IV nitro. So of the 48 patients who got the IV nitro, they actually presented very well with it. So these paramedics, what they did is they said, okay, here's a patient with acute pulmonary edema, treat them. And if they were their blood pressure was high, then they can choose to give the IV nitro. So they tried Duonebs, they tried sublingual nitro, some of them tried Lasix, some of them just took them into the hospital. So when the parameters hit and they tried what they wanted to try, and their systolic blood pressure is still greater than 160, then they hit them with 1 milligram of nitro every 5 minutes. All right. Upon initial presentation, systolic blood pressure was 211, and after 1 milligram of IV nitro, it dropped to 177. Huge difference, huge drop, which is great. That's beneficial. The mean heart rate was 113 beats per minute, and after 1 milligram of IV nitro, it dropped to 103 beats per minute. And the biggest significant factor here, the SpO2, it would increase from 86% to 98% after 1 milligram, one dose of IV nitro. So again, these patients dramatically improved, which is why, again, IV nitro is safe and effective. And finally, the last study that I'd like to cite for you is the North Memorial Health Ambulance and Air. They actually are in Wisconsin, in Minnesota. And what they have is they had 44 acute pulmonary edema patients. Initially, what they did is, again, if you had acute pulmonary edema, they gave you 2 sublingual nitro tablets for a total of 0.8 milligrams. And then afterwards, they established an IV and gave 400 mics of IV nitro every 2 minutes with no max dose. And they gave the IV nitro all the way until the systolic blood pressure dropped below 120. Again, the initial presentation, the average blood pressure was 191 over 113. 5 minutes after IV nitro, blood pressure was 160 over 94. A huge decrease, which is great. And again, as we're seeing the trends, it had an increase of oxygenation, SpO2, from 88% up to about the 92 to 94% range. And that's 5 minutes after IV nitro. There's only one episode of hypotension that resolved on its own. So again, we can conclude that IV nitro is safe and very effective. So let's look at the protocol here. The protocol is the same layout that we're seeing. The universal patient assessment, we want to put the patient on capnography and nasal cannula and figure out what that is. We want to titrate the oxygen percent to 94, and we want to repeat the vital signs every 2 minutes. And the reason we're doing vital signs every 2 minutes is because you're going to see the treatment is to give 1 milligram of nitro every 2 minutes until the patient improves. Get that 12-lead done within 5 minutes if possible. We want to make sure it's not an inferior wall MI or it's bradycardia causing the acute pulmonary edema. We want to transmit a respiratory cardiac events. You know, like Matt said, instead of hitting STEMI, just hit respiratory or hit cardiac and get that cardiologist on the line to look at that, especially with triage. Those notifications are going right to the cardiologist's phone, and they can advise you further in a chat feature what to do next. Apply the CPAP. Remember, with this, we want to make sure that we start at 5 to 10 and rapidly titrate as necessary. Get that IV, and if you're having trouble getting that IV, or you might want to dose them with a sublingual nitro, go ahead and do that. And again, be aggressive. If the systolic blood pressure is greater than 100, we want you to pop in a nitroglycerin to have that effect on that patient. I told you that we're going to break these into 3 categories: mild, moderate, severe, and then cardiogenic shock. Well, your CHF patient that's not sympathetic induced crashing, we're just going to go ahead and treat them normally. All right, these blood pressures on these patients are less than 160. Their heart rate will be around the 70s. They're going to be normal. They're not going to be high. We're going to go ahead and give them some sublingual nitro every 3 minutes. And the EMT can do this too. The state says you have to call Trumbull, so we're going to go ahead and call Trumbull, and the EMTs can give some sublingual nitro. So these are the patients who we don't have to rapidly treat. They have some CHF, some crackles, but they're going to benefit from some venodilation. When we give the IV nitroglycerin, these patients are going to be the moderate severe category, and their systolic blood pressure is definitely going to be high. It's going to be around 160. They're going to be tachycardic. You're going to see them. They're going to be air hungry. Their SATs are going to be low. All right. We're going to give them 1 milligram of IV nitroglycerin every 2 minutes until the systolic blood pressure decreases below 140 or the symptoms resolve. All right. If these patients are anxious for any reason or they can't tolerate the CPAP, feel free to go ahead and give them a little bit of Versed, and that's going to help, one, decrease the blood pressure, but two, make them less anxious so the CPAP can work. If they decompensate after 20 minutes of treatment, you're still not at the hospital for whatever reason, then we might have to go to the delayed sequence intubation, which is going to be a whole separate lecture when we release our respiratory protocol. And again, if the heart failure is so severe that we lose our blood pressure and we lose our heart rate, then what we're going to do is we're going to see what that blood pressure is. If that blood pressure is less than 90, we're going to stop CPAP and we're going to give epi push dose pressor because we need to increase cardiac output. So what I want to do right now is I want to give you a little case study. This is from a EMS crew in our system under Trumbull, and this patient was at Dollar General, and they were found in the driver's side of her car. And let's look through the medical history here. Medical history is COPD, congestive heart failure. They're on Cardizem. They're on Duoneb. They have some emphysema. All right. They're also on Lasix. They're typically on oxygen. And let's look at what happened. Upon arrival, the patient's sitting in the driver's seat of her car in respiratory distress. The patient friend states she became short of breath in Dollar General. They got her to the car, and the patient's oxygen tank was empty. All right. GCS is 15. They're alert and oriented. Bilaterally, they have crackles. All right. So EMS went ahead and put on 15 liters non-rebreather until they figured out what was going on. The skin was cold, dry, and pale. The patient was cyanotic, and of course, they had decreased breath sounds. Edema was noted to the extremities. So it sounds like this patient is in CHF. Upon arrival, the 63-year-old female sitting in the driver's seat, they went ahead and put the patient on a non-rebreather. The SpO2 is registering 35%. And we know that SpO2 below 70 is not very accurate. But look at this. They're breathing on 40 times a minute. So we know this patient's distressed. We know this patient isn't getting oxygen. They have cyanotic lips. All right. So the patient, the EMS crew went ahead and they tried to further diagnose what was going on. They went from the car to the cot where they could do some more assessment. The patient was tachycardic. Their blood pressure was a little high, 144/64. All right. Respirators were in the 40s, and they were breathing so quick it didn't capture on their end tidal. So because she had the history of emphysema, they went ahead and gave 2 Duonebs to try to open her up a little bit more. And then they established an IV. They did a saline lock. And then after they got the saline lock, they actually gave the 0.4 milligrams of nitro. And then the patient started to improve. The patient improved. The blood pressure dropped 126/72. The heart rate came down, and SpO2 increased. So they were actually able to wean that patient off of the non-rebreather, and she maintained 97% on her normal 4 liters of oxygen. So with this patient, we knew that they were in respiratory distress. We know they have a history of congestive heart failure. The patient had crackles. The patient had edema. And we can see the trend that her blood pressure started to increase. Her heart rate started to increase. So this patient was 1 or 2 steps before the sympathetic-induced crashing acute pulmonary edema. I think this patient would have benefited from IV nitro, even though it didn't meet our systolic blood pressure of 160. But you can see that this patient is trending towards the release of the catecholamines. And again, maybe that sublingual nitro could have been given a little bit quicker. That patient could have been put on CPAP to go ahead and try to alleviate that congestive heart failure a little bit quicker than waiting for that IV to be established. But in the end, the patient improved, and that's what we want. We're looking for patient improvement to decrease morbidity, mortality, rate of intubation, rate of ICU stay. So what did we learn from today's lecture here with the acute pulmonary edema? We learned from different studies, and there are more studies out there that say that IV nitro is safe and it's effective. All right, it's very effective. The IV nitro decreases systolic blood pressure by about 20%, and we've seen from all the studies that it increases oxygenation, that SpO2 is increasing from the 80s up to the 90s, right where we want it. All right. With COVID-19, if we ever have a ban on nebulizers or CPAP again, and you don't have the filters to do the CPAP, we might be able to give these acute pulmonary edema patients IV nitro to allow the arterioles to dilate so that they can have more space in their system to compensate for that fluid, preventing the release of the catecholamines, so that we can just maybe help do them until they can help improve those outcomes until they can get into an isolation room. And the most exciting thing is we're going to be one of 3 currently in the country utilizing IV nitro in the pre-hospital setting that's not doing a study. So this is cutting edge medicine. The cases are out there, the research is out there, and we're bringing it to you in all these peer-reviewed journal articles to be cutting edge, and that's what we want to do. So nitroglycerin will be in a vial. This nitroglycerin, this is the exact nitroglycerin that you're going to see in your box. It's on the top shelf, the 3rd space in the back. And again, what we're going to do, we're going to take a 10 ml saline flush. We're going to waste 1 milliliter. We're then going to draw up 1 milliliter of this IV nitroglycerin. The concentration on the syringe that you're going to label is 0.5 milligrams per ml. So again, the protocol says we're going to give 1 ml. So that means we're going to push 1 milligram, which means we're going to push 1 ml, which is 1 milligram, every 2 minutes as necessary until that blood pressure drops below 140 or the patient improves. Very easy stuff. This is cutting edge stuff. This works very well. And I encourage you to use it and give us some feedback when we do use it.
Wow, Larry, thanks, man. Like I said, Larry's put a ton of work into that. Obviously, he's done his homework on it. Anybody who knows Larry knows that that's the way it goes with him. So that's a good thing. I'm going to just touch on the blood draws again. I can't emphasize this enough. I know for some of these guys, some of the older guys that have been here for a long time, we've been through the blood draw thing a couple of times, and it never seems to work. Well, I can tell you right now that it is working. It's working in-house, and it's changing the way people are being treated here in the hospitals. This is the typical blood draw kit you're going to see with the form and the paperwork, all packaged in this bag. Right now, there's 6 tubes in the bag, a vacutainer and an adapter. As things progress, there may be some things added to the bag. We might, as our sepsis protocol progresses, we're probably going to be drawing blood cultures in the field, and there will be special swabs, cleaners to use before we draw those bloods. But for now, this is the typical blood draw kit. These tubes right here are sitting in their order of draw. The order of draw is determined because these different tubes have different chemicals in them, and we would not necessarily want the chemical in this tube to contaminate this tube. So these are done in a specific order. That order is on the form inside the bag. Please follow the order. As long as we stick to the order and we stick to the process, these blood draws are getting used and being used to drive the patient care and to slice some time off. Inside, you'll find these little address labels. There's 6 of them, one for each tube. They do need filled out and stuck on the tube. I just thought it'd be a lot easier to write that on a sticker and put it on the tube than it is to write on a little round tube. Furthermore, here's our form. This form must also accompany. And again, if you don't have this all filled out by the time you get to the hospital, the PCT or the RN or whoever's there again, they're not going to dispose of it because you didn't have the form filled out. They're going to assist you in using these samples. So if you do need help, don't hesitate to ask, and ask early. So these all need filled out entirely also. And you can see here's your order of draw. Blue, gold, green, lavender, pink. And I sing that song in my head from making 1 million blood draw bags. So the odds of me ever forgetting the order are probably pretty slim, but right here's the note. This is exactly the order you do it in. Here's the procedure. And again, one thing on this I want to show you is that over here you see that this might be red speckled or gold. we're 99.9% of the time going to be with the same manufacturer, so it's gold. This is just in here because if something happens and we have to replace gold with red, then you understand. Here's your whole procedure. These are skills that we already have or should have. If you need any remedial training on them or any points, please let me know. That's not a problem at all. Whoops. But these are very important to us to be used in the ED. From top to bottom, people in the hospital are excited that we're doing this, so it's important that we keep it up. So I would like to really thank everybody for coming and giving us your time and your attention. I hope you use these protocols in good health for you and good health for your patient. Like Larry was saying, these protocols are safe, they're effective, and we want your feedback on them. Especially if you use them for the first time or anything, I want your feedback on them. To that end, in most of the departments around us and in the ED, there's a QR code. There's a form with a QR code looking for feedback and for patient referral or patient follow-ups and things like that. Please feel free to use that, or call me or email me or whatever other way you need to get in contact with me, and let me know what you think about these protocols. In order to get any kind of credit for participating in today's lecture, I'm going to need you to scan this QR code and follow the directions and fill out the form that it takes you to. If you do have any questions, please don't hesitate to use any of those modes that I gave you. And this is also my email address here at Steward, matthew.gordon@steward.org. Use any way you can to get to me, to ask questions. We're willing to answer questions and take your suggestions. Once again, thank you very much and have a good day.